Thank you very much, Vijay, for your kind introduction and also the invitation. This evening I'm going to talk to you very briefly in about 10 minutes on the possible ways in which you can design a PKPD study in brain metastasis. Okay, so now why do you want to even design a PKPD study for brain mets? So I think the simple answer for any PKPD study is it will help in optimizing the dose. And that goes with the premise that the standard dose that you use for treating, be it lung cancer or breast cancer, may not necessarily be useful for treating brain metastasis, and that we have seen through several examples, from speakers that spoke before me. And one example Vijay just mentioned was about osimertinib, which was tried at 160 milligrams, as against the conventional 80 milligrams that it is used, for the treatment of lung cancer. So the question is, can we optimize the dose for brain metastasis? So before we go for optimization, it is important to understand a little bit about the blood-brain barrier and the blood-CSF barrier. And we should all appreciate the fact that, it is not the same. Because, what we are going to measure when we are doing any pharmacokinetic study is concentration in CSF. But that is not necessarily the concentration that we achieve in the brain extracellular fluid. And more importantly, that's not necessarily the concentration that we achieve inside the brain cells. And this cartoon here will help us to understand the blood-brain barrier and the blood-CSF barrier a little better. And one must understand that, the analytes or solutes or drugs, whatever, can move from the cerebral blood into brain, across the blood-brain barrier, through the brain ECF and to the brain cells. And likewise, there is also a blood-CSF barrier. And most importantly, there is also some communication between the brain and CSF. So it is not as though they are actually in isolation. So there is some communication. And it is possible that, some equilibrium may be achieved between the brain and CSF levels, but not necessarily. And here again, understanding what are the transporters, whether the drug is simply diffusing across membranes, or is there a facilitated transport, like in the form of active transporters, like be it BGP or ABCB1 or whatever, whether they are involved. Understanding those things becomes little important. In order to know whether the concentration that are achieved in CSF is a reflection of what is achieved in brain. But this is just to tell you that, we must be little kind of careful while interpreting the CSF concentrations. Okay. And just, what I spoke in the previous slide, whether the CSF concentration is the same as blood concentration, and, how does the, brain distribution differ from CSF distribution, and why should we do, PKPD studies? So what are the different ways? See, if you have more sophisticated ways of, studying pharmacokinetics, we actually look at the concentrations of drug from preclinical models, like rat models or whatever. Look at the CSF concentration, look at brain concentration, and you can actually scale them up. Scale them up to what the drug is likely to behave in humans. But now we may not necessarily have access to all those preclinical modeling and everything. So therefore, we have to settle for something that we can do. And what we can do is we can do CSF sampling. And now in the next 7 minutes, my job is to convince you are as good, at predicting, what the outcomes are going to be. And one must understand that, when we do pharmacokinetics also, like for example, if you, when we're taking a drug through its development phases, phase 1, phase 2, and phase 3, we all know that, we do pharmacokinetics in phase 1, and there typically we are looking at the blood levels. But that does not necessarily tell us about the levels that are going to be achieved in lung or kidney or stomach or whatever. But still we do blood levels, and then, we can make predictions based on those levels. Likewise, it is a similar case for brain metastasis also. If we can know the CSF levels, it's one step closer than just looking at the blood levels and making predictions for brain concentrations. So, and then we all know what the challenge is as far as brain metastasis are concerned. And there is this wonderful paper by Dr. Narona, which actually lists the dismal outcomes with brain metastasis. And this is a very well-known fact. And for the same reason, we designed a very simple study it was just, you could say it was some kind of a phase 1 feasibility study to understand whether we can deliver higher doses of TKIs in patients with brain metastasis. And why higher doses? That is because of everything that we learned throughout the afternoon, that most drugs achieve lower concentrations in brain. So the idea was to see whether we can use higher concentrations. Now we chose two TKIs here. One was erlotinib and the other one was gefitinib. And erlotinib as such is dosed very close to its maximum tolerated dose of 150 milligrams. So what we did was with erlotinib was, instead of giving it daily, we thought we'll use a pulsatile high doses. So we use 1500 milligrams once a week. 1500 milligrams once a week. But for gefitinib, the maximum tolerated dose is about 1250 milligrams, which is almost 5 times more than the standard dose of 250 milligrams. So therefore, we thought we could use 1250 milligrams on a daily basis for gefitinib. So that is the difference between erlotinib and gefitinib. And what we did, the idea was to use these drugs for one week at standard doses, and then change over to higher dose, allow them to achieve steady state concentration, and look at the drug levels on the 7th day, because that is when we expect the steady state to be achieved for these drugs, 7th day. And the way we designed it was, we collected the paired samples, on 7th day after the standard dose, let's say. Let's talk only about gefitinib now, because it is easier to understand, because the dosing for both standard dose as well as high dose was on a daily basis, so it is far easier to understand. So on the right hand side, the panel B is about gefitinib, and what we saw there is, if you are giving gefitinib every day and looking at the plasma concentration 4 hours after the 7th day dose. Why 4 hours? Because we thought we'll look at the time when the concentration is likely to be maximum. And we know that the time to maximum concentration for gefitinib is 4 hours. So we looked at the plasma concentration, and we also took a paired CSF sample. Okay. And we repeated the same thing once we switched over the patient from a standard dose to a high dose on day 8, and allowed 7 more days. And on the 7th day of the high dose, we also once again took a paired plasma and CSF samples 4 hours after the 7th day dose. And what you have here is, on the left hand side, you have the plasma concentrations of standard dose and okay, I don't know how to show that. In panel B. Okay, so the first figure in the panel B, you have plasma concentrations following the standard dose and the high dose. And in panel B, the right hand side, you have CSF concentrations. And what you will understand here is, when you look at the penetration, the CSF penetration was better at standard doses as compared to high doses. How do you know that? The penetration here we have defined as the ratio of the CSF concentration upon plasma concentration. And for the standard dose, the ratio is coming to 4.4%. Okay, and for the high dose, it is coming to 1.9%. So what does it tell us? It tells us that there is some saturation happening, and that is not very difficult to understand, because since it has to go through several transporters, they can saturate. So what we did was, we plotted this plasma concentration versus CSF concentration, and we found that that saturation becomes very, very obvious. So and then we could fit this data using Meckel's-Menten equation. And if you want to know what Meckel's-Menten equation is, if anybody is familiar with your 12th standard biochemistry or whatever, enzyme kinetics. So wherever the enzyme kinetics saturate, it follows what is called as Meckel's-Menten equation. So any saturation kinetics, the preferred way to fit a saturation kinetic data is using Meckel's-Menten, although there are various other ways of doing it, and Dr. Atanu will be able to help you better with that. So when we fitted this, what we observed was a concentration of 800 milligrams in plasma is when the CSF actually saturates. So as you can see, there is a very steep rise, and then it flattens, and the flattening happens around 800 milligrams of plasma concentration. So now we have average concentration that is achieved at 250 milligrams. We have the average concentration that is achieved at 1250 milligrams. You draw a line, and you know that if you have to achieve plasma concentration of 800 milligrams, because that is where the CSF saturates, what is the dose you should give? And that dose comes to about 839 milligrams. Okay, so basically, if you give a dose of 839 milligrams, you will achieve CSF concentration, and beyond that, the concentration is not going to increase. So therefore, we concluded that a better dose. I mean, if you have to give high dose gefitinib, the best dose to give would be 750 milligrams, because beyond that, you are not going to achieve any higher concentrations in the CSF. So this is one kind of optimization that we did. It is a little crude optimization, I would say. I mean, this is not the best way to optimize, and I'll tell you what were the fallacies of the study. But at least, we could find out, where the concentration saturates, and we could decide that, okay, beyond 750 milligrams, patient may not benefit. And so what is the mistake we did here in this study was we took only one sampling time point. So we took at 4 hours post-dose at steady state. But had we taken multiple samples from plasma, because plasma sampling you can do on multiple occasions, even if CSF you can do at only one time point, we could have varied the CSF sampling for different patients. Like, for example, for one patient, we could have taken at 1 hour. The second patient, we could have taken at 2 hours, 4 hours, 8 hours, 12 hours, whatever. So if you had varied that, so we could have actually got a pattern, and then, we could have kind of fitted those lines using those the simulations, and that would have actually told us how so even with just 1 day sampling, it would have told us how the plasma concentration would have behaved at the high dose, and how the CSF concentration would have behaved at the high dose. And this is likely to give us a better understanding of the CSF levels. So, and this is something which we could have done, and that is exactly what we are planning in the study that Vijay proposed in his previous talk. So, now, so that's about pharmacokinetics. So the only message I want to convey here is, instead of taking just one paired samples, if you can take multiple PK samples from blood, which is central compartment, and then pair at least one sample for every patient at different times in the concentration time profile, you will be able to get a better idea about the concentration time profile in the CSF, and then we will be able to optimize the doses better. And my next part of the talk, which is just one slide, is about biomarkers. And I don't think there are any great biomarkers, for brain metastasis. And therefore, so if you have to take it, the best thing that you can take is imaging biomarker, because the imaging biomarker may actually tell you whether there is what is the change, what is the delta change in between pre-treatment and post-treatment levels, and then you can actually fit that using this kind of a model. This is called as a Emax model. So wherein what is the difference? That is the actual treatment effect. The treatment effect is difference at baseline minus the maximum treatment effect. Plus, so you get certain kinds. So then you can actually calculate the dose at which you are going to get the Emax effect. So the dose that you are going to get the Emax effect is D. So you will actually be kind of calculating the dose which will give you the Emax. So you can actually replace D with concentration also. Then you will get an idea what is the concentration that will give you the maximum effect. And because you would have modeled the concentration time profile, you can easily calculate the dose that will give you the desired concentration. So that is how you actually model the data. So this is called as a link model, which will link your dose with the concentration with the effect. Okay, so that's about my small talk for this evening. And just to conclude my talk, pharmacokinetic studies in patients with brain metastasis are scarce, but if you can do it with proper planning, you may be actually able to come up with proper, optimized doses for the treatment of brain metastasis. Okay, that's it from me. Thank you.
Do we have any questions for Vikram, sir? So, I have one. So, do you think CSF dosing for leptomeningeal should be actually not via the traditional model of looking at adverse events, but via the Emax model, that link model?
Yeah, see, I mean, definitely, see, when it comes to the response, you can use the link model, but still the adverse events will become important, because that will tell you what is the maximum dose you can deliver, because, beyond which you cannot deliver anyway. So that will help you to, help you to set the MTD, but otherwise the actual dose optimization can happen through the linking.
So would it be better if I say that in drugs which you don't get the MTDs or DLTs, like in immunotherapy or for targeted therapy, where you keep increasing the dose and we never got the MTDs. In those, this model would be the better one.
Definitely.
The one.
See, that's the whole point of proposing that the Michaelis-Menten model. No, so that is what we said. No, you don't have to go till 1250 because 1250 you are not getting any higher concentration CSF than what you would get with 750 milligrams. So essentially, that's what would translate to to answer your question. So the highest dose is the highest safe dose is not necessarily the optimal dose. Yeah.
Highest safe dose may not be the same. So would you be doing some kind of this work in that nivolumab pharmacokinetics or dynamics which you are looking at, where you would have?
No, we don't have CSF sampling there. No, we have
so
only.
you would have blood sampling, no? But
Yeah.
This similar model.
Yeah,
could be
we
used
can
for
do.
blood,
So
blood
population,
modeling also.
PKPD modeling we can do definitely.
Yeah,
Yes.
because there I could understand that saturation happens at much lower dose, and we could have this kind of model which could give an answer what will the optimal dose for this drugs.
Absolutely.
Yeah.
Absolutely. Yeah. Although the sample size is also becomes important. I mean, we can't perhaps do that with 20 patients.
What would be the sample size for such cases? Because that's interesting. The reason why I was telling you about this is because when they did the traditional phase 1s for immunotherapy, they went up to 200, 300, 400 because they didn't reach a DLT. So that's the reason why I was just asking you.
So see, everything depends on mathematical modeling, right? So in modeling, there is a dictum. The dictum is all models are wrong and some are useful. So when does the model become useful? When there is as much data as possible. So there is no ballpark as to what is the number of patients you take. But the more patients you take, the better fit will be the model, and then better will be your conclusions.
Any ballpark number that you would require this much patients? Because I see you need to tell this much patients, sir. Or else it won't approve your study, sir.
So when we do covariate model. So when we do covariate model, we generally take 10 patients per covariate. That is the ballpark we take. So depending on how many covariates there are. So there could be PK, there could be something else, there could be something else. So yeah.
Okay. So with that 25 patient data for 2 covariates, you could do that modeling.
Okay.
Vikram,
Sure.
any role other than research settings, so any role in clinical practice that you can envision to be checking PKPD for patients who are on TKI, maybe not responding? Any thoughts in practice?
I mean, actually, yeah. Like for example, we developed a very nice strategy for monitoring sunitinib levels. So we did TDM, therapeutic drug monitoring study, and we found out that if the level of sunitinib, concentration of sunitinib, tough concentration on day 10 is less than 60 nanogram per ml, there is a higher chance of failure. Likewise, if the concentration is above 80 nanogram per ml, there is a higher chance of toxicity. So we could define that window that if you can maintain the concentration between 60 to 90, and in fact other centers have shown 50 to 100. I mean, that can vary depending on how the patients behave. So we could define that window. So if you have a defined window like that, then you do therapeutic monitoring because you have the data. But if you don't have the data, you can use modeling to actually arrive at the concentrations that are necessary to get you efficacy, and then defining the threshold as to what threshold has to be maintained. I mean, most drug will have that exposure effect relationship or concentration response relationship. But for some drugs, you cannot establish it. But for TKIs are a very good candidate, for establishing the concentration response relationship and then dosing according to the desired cutoff concentration. That definitely is possible for most TKIs. Yes.